All right, good morning. It is 11 o'clock and we are going to get started. Thank you so much for joining us today. I'm Carrie Fink, your moderator for the session titled The Doctor is in Q&A. And we have about uh, 25 folks joining us so far. I know we have a few more hopping on as well. If you think you have found yourself in the wrong session, you can just go back to the conference homepage tab and click on the title that you want to attend. A reminder that the conference sessions will be available for your viewing 60 days after the conference with a link that will be sent to you after the conference is over. I will be introducing the presenters and then we'll be taking your questions using the chat feature. So you can post your questions using the icon found on the bottom of your Zoom screen. We may not be able to get to all the questions, but we will do our best to summarize and respond to as many as possible. We recommend using the side-by-side speaker view with the buttons in the upper right-hand side of your Zoom screen. And if you have any technical issues with the session, you can click on the email button on the conference homepage to submit your questions, and those will be answered in real time. So without further ado, I am honored to introduce today's speakers to you. The first is Dr. Terry Barclay. He's a fellowship-trained neuropsychologist with research and clinical expertise in aging and dementia. He received his doctorate in clinical psychology from Michigan State University with residency training in geropsychology at the West Los Angeles VA Medical Center. He went on to complete the NIMH postdoctoral program in neuropsychology at the David Geffen School of Medicine at UCLA, where his research focused on cognitive, behavioral, and psychological changes associated with normal aging, Alzheimer's disease, and other dementias. Dr. Barclay is currently the clinical director of neuropsychology at Health Partners and Regions Hospital in St. Paul and an adjunct associate professor of neurology at the University of Minnesota. He specializes in neurodegenerative disease and timely detection of cognitive impairment in the geriatric population. He has led the development of a range of evidence and consensus-based tools for healthcare providers that have been adopted and utilized by systems in Minnesota and around the country. Dr. Barclay also works with federal agencies and a wide variety of healthcare organizations to develop professional education curricula and instructional videos that are used to train physicians and other healthcare providers at major universities and healthcare systems throughout the US. And Dr. Rosenblum is a behavioral neurologist based at the Health Partners Center for Memory and Aging in St. Paul, Minnesota, where he serves as the clinical director and chair for the Department of Neurology. He attended medical school at the Columbia University College of Physicians and Surgeons and received his neurology training at the Harvard program at Mass General Hospital, Brigham and Women's Hospitals. He completed a behavioral neurology fellowship at the University of California, San Francisco Memory and Aging Center, focusing on Alzheimer's disease, as well as atypical dementias such as frontotemporal dementia and rapidly progressive dementia. Thank you, Dr. Rosenblum and Dr. Barclay, for joining us this morning. And it looks like we have 36 participants here on. And without further ado, I would love to open up the chat feature and start taking your questions for the doctors. And you are also welcome to turn on your camera if you are comfortable.
Yeah, I put in 4 paragraphs in the chat. I don't know if anyone has had that kind of thing happen in their particular case. However, it's 4 paragraphs. I couldn't get it all into one copy paste. I kind of did a little language in advance of the meeting. That's why it's all chopped up, because it wouldn't fit in one chat. So thanks.
So I am not seeing anything in the chat just yet.
Yep,
Really?
it came straight to me, so I'm gonna put it back in here for you guys.
Thank you.
Well, as we wait, maybe we'll kind of tell you a little bit about kind of our current interests. As you heard, Dr. Barclay and I work together at the Center for Memory and Aging. We're actually right now working on several initiatives. One of them involves a approach to encourage overall wellness in patients. We call it the NeuroWell program, and maybe I'll have Dr. Barclay talk about that. The other area of interest that we have is using certain imaging modalities to look at the brain networks in patients with different types of dementia, like Alzheimer's disease and Lewy body dementia. And this is a type of imaging program that allows us to it's called functional MRI, and it allows us to look at the what we call large scale brain networks in patients. And, there's a certain type of finding you would get in Alzheimer's disease versus other conditions like Lewy body dementia. And then we hope to eventually move in a direction where we're evaluating one modality. It's called transcranial magnetic stimulation to kind of stimulate some of those dysfunctional networks in patients. And that's some type of an area of research that we hope to do. Traditionally, this has been used in patients with depression by psychiatrists, but you would imagine that if you have this tool that allow us to make changes in the function of the brain to affect depression, well, could it affect memory as well? And so that's something that we're currently working on, and we finished our fundraising. We expect to start that toward the end of the year. We also have the usual run of clinical trials that take place here at the Center for Memory and Aging. And then also we have a program called the Care Ecosystem that allows us to provide kind of the continuum of care for patients, mostly to support caregivers. And we have a team of a social worker and also two case managers who work closely with me. And, we'll connect with the families periodically to ensure that there are no active issues or concerns. Or if, let's say, there's an active need, the family needs help with transitions of care, this is somebody who can kind of hold their hand through the process and direct them. So those are just some programs that are ongoing, some research that is ongoing. The NeuroWell is a really fascinating concept and initiative. And maybe Tara, do you want to say a couple words about that? Also, feel free to add anything else that you think is worth mentioning to the group.
Sure. Good morning, everybody. Thanks so much for joining us. Again, my name is Dr. Barclay, and I'm a neuropsychologist at the Health Partners Center for Memory and Aging. My team and I do a special type of brain testing that's used to help narrow in on a specific diagnosis for patients who are concerned about memory loss or other changes in thinking or behavior. But beyond a diagnosis, I think for both Dr. Rosenblum and I and the rest of the team, we're really passionate about not just a diagnosis, but making sure that people are connected to the right services and supports, have a game plan, are planning ahead, have good communication with family members and friends, and can basically move forward after seeing us to live their best, fullest life possible. In my experience, 90% of dealing with memory loss or cognitive changes, dementia, is not about drugs or medication treatment. It's really about all the other ways that we can be educated and support each other through the process. And so, as Dr. Rosenblum mentioned, our vision of NeuroWell is all about wellness-focused care. And so after a diagnosis, in addition to talking to patients and families about potential medication therapy, if they're interested in that, NeuroWell is really about the other 90%. And it starts with proactive planning and goal setting. We believe that strong communication and education about the diagnosis, about the symptoms, what to expect now and in the future is really important so that people can plan ahead. We connect people to whether it's social workers or care navigators to help in that process. We also want families to start communicating with each other, to talking and sharing about their values and their priorities. And the rest of NeuroWell also makes sure that every person in other ways has what they need to live their best life. So for example, there's a section on emotional wellness, making sure that the grief and loss that can be associated with the diagnosis is addressed. Making sure that there's joy, meaning, and purpose in life. Just because you have a diagnosis of dementia doesn't mean that there's no life to be lived. So how do we connect people to those sources of joy and purpose and meaning? Another section of NeuroWell deals with social support. We're social beings and we need to feel like our relationships are strong. And sometimes after a diagnosis, that can be really hard. As someone is experiencing memory problems, for example, I had a grandmother with Alzheimer's, and I noticed that family members and friends started to fade away in the distance, not because they didn't care about her anymore, but because they just simply didn't know how to navigate conversations and the relationship once she became more impaired. And so we want patients and families to be focused on that. And the rest of NeuroWell is making sure that people have opportunities to strengthen their bodies, because we know that there's such a strong connection between physical activity and brain health, making sure that the home is safe, that their people are not falling or running into other challenges that lead to unnecessary hospitalizations and more untoward consequences. Finding other ways to make sure that people can live independently for as long as possible, because of course that's the goal for most of us. And so this is just a little bit of a high level flavor of our concept about wellness focused positivity, and making sure that people have the tools that they need and that they deserve after a diagnosis. So I'll stop talking, but please answer or ask any question that you have. There's no dumb questions. We're here to make this tailored to you. So
Great.
here,
We
do
had
we have any questions?
one come in that's great to kind of start us off here. How can I tell if my parents' memory loss is just normal age related at 89 years old versus dementia?
That's a really good question, and one that I think is on the minds of a lot of people. You know, as we get older, we all experience some subtle to mild changes in memory. The speed of our thinking slows down a bit, and it's also very common to have some word finding difficulties. So there is a normal aging process that does lead to cognitive changes. But the real tipping point is when those memory or cognitive changes start to interfere with what, as clinicians, we call instrumental activities of daily living, or the ability of a person to really independently manage their lives. So when memory loss starts to interfere with, for example, someone's ability to keep track of appointments, maybe a loved one is missing appointments, asking 5 times about the details of an appointment, writing things down but losing the notes. Maybe they're forgetting to pay bills, having more confusion about financial matters. So it's really about when there's starting to be a change in those IADLs, that ability to live independently. But of course, anyone concerned about a loved one, particularly an individual in their 70s, 80s, or older, it's always a good time to get an evaluation. Primary care can do a quick cognitive screening test, the score of which can help determine if memory loss is normal or not. And of course, at the Center for Memory and Aging, we see patients who are asking these questions all the time.
So the other thing I would add is that, you know, those are some of the subjective features that you may experience at home and signs to look for. Dr. Barclay also has a great battery, his neuropsychological battery, where when somebody is being tested, he's able to compare people's performance with age-related, age-matched, education-matched controls. And so this is a nice objective way in the setting of the clinic to say, truly, is one's memory the same or different compared to normals their age? So that's another way. Let's say if somebody's not sure, we can certainly test them in the clinical environment and make some type of conclusion based on that, the results from the neuropsychological testing.
Thank you.
I also see that there's a direct message to me from Deb about, and maybe this is not apparent to everyone, but I'll answer it because I see it's the next one. How much impact have the latest medications have on prolonging clarity and cognition? What are the latest drugs being used? And I just want to make everyone aware, and I think this may answer some of the other questions lower below, that the medicines, they're in two different buckets. One are the cholinesterase inhibitors. These are drugs like Aricept, galantamine, rivastigmine. And then there's, and what these do is that they block an enzyme that breaks down this chemical acetylcholine. This is present in part of the front of the brain. We call it the basal forebrain. It helps connections between brain cells. And as Alzheimer's progresses, those cells die, and as a result, the ability to for these neurons to communicate with one another is compromised. So what you're doing is you're helping the neurotransmission between these brain cells by giving a drug like Aricept. There's another, and just so you know, these medicines are typically approved for mild, moderate, severe stages of Alzheimer's disease. There's a drug called Namenda or memantine. That's the second bucket of drug. And this is a drug that likewise helps connections. Formally, we say it increases the signal to noise ratio between neurons. And it all boils down to communication between your brain cells. And it's given twice a day. It's approved for moderate to severe Alzheimer's disease. My overall gestalt after, treating patients with these drugs for over 10 years is that they're quality of life medicine. So they're not going to necessarily slow the disease progress. They're not disease modifying. Essentially, they're treating symptoms. So if somebody is bothered by their cognitive impairment, then it's worth trialing it. But it's the clinical trials that have been done evaluating these drugs have shown modest benefits at best. And so they're not impacting what is driving the disease process, which is essentially these amyloid plaques and tangles. Those are the two neuropathological markers for Alzheimer's disease. So these plaques that form in the brain are consisting of this A-beta protein, and then it forms these giant plaques called amyloid plaques that are found outside of cells. And then you also have these neurofibrillary tangles that are clusters of this tau protein that are found within brain cells. So currently, a lot of the clinical trials are developing drugs that are designed to bind to these abnormal proteins in the brain, like the amyloid plaques or the tau forming the tangles, and take them out of the brain. And the hope is that these will be disease modifying. They're designed to be disease modifying, but we don't know that yet because the clinical trials are currently ongoing. So that may be the future of treatment in this disease. But to answer that question, the drugs that we have right now are symptomatic treatment, and the benefits are modest at best.
I got a question. Can you speak to anything regarding preventative measures? Alzheimer's runs in my family. My dad has it as well. My siblings and I are wondering if there is genetic testing for it.
And this is something that I think both Terry and I can take this question. So, we in the past worked extensively on what's called the Living Well workbook that's available online if you search it on Google. And this is an effort that led us to reviewing all the literature about preventative measures to address that very question. There was also a trial done in Finland where they actually had a randomized double-blinded placebo intervention that included things like cognitive activity, physical activity, optimal medical management for, let's say, hypertension, things like that, diet. And we know that a lot of those components that are non-pharmacological at least in normal aging patients and also in mild cognitive impairment, can reduce the risk of dementia later on in life. So if you take somebody who's, let's say, in their 50s and 60s, and you look at their lifestyle. So somebody who is physically active, and we're talking about 150 minutes of aerobic activity per week, and you compare them to somebody who's more sedentary, that population that's more physically active will have a reduced risk of dementia later on in life. The other thing is that you look at is the cognitive activity. And so this could be something that involves reading, writing, trying something new, playing an instrument. Those people who are more cognitively active compared to those who are less active, they see that there's a reduced risk of dementia later in life. And then socialization, which is extremely difficult in the time of COVID. And actually, it's hard to sometimes separate that from the cognitive activity, especially if we're talking about games and social events. That also is important because we know that those who live alone or who may be divorced or isolated, the risk of dementia is greater in that population. In terms of diet, we always talk about the Mediterranean diet, which is fruits and vegetables, olive oil, less saturated fats and red meat, fish. That's a really helpful diet that, again, those who are more adherent to that diet early in life will have a less or reduced risk of dementia than those who are not adherent to that type of diet. So those are a lot of the various factors that may contribute or protect against dementia later on in life. And I'll turn things over to Terry because he's thought a lot about this topic as well.
Thanks. I think you covered it really well. I would just add a few more things. Of course, going to see your doctor regularly for annual exams to make sure that you're on top of any underlying medical conditions. Managing cerebrovascular risk factors is also really important because we know that things like uncontrolled hypertension or high blood pressure, high cholesterol, uncontrolled diabetes, obesity, all of these issues can put pressure on the blood vessels throughout the body, including in the brain, and accelerated breakdown of blood vessels in the brain does hasten memory and cognitive changes and is linked to the onset of Alzheimer's disease and other dementias. And so managing your health, but specifically also the cerebrovascular risk factors. Other things to be thinking about, of course, not smoking, which is another risk factor for vascular disease. Managing alcohol use. We do see a fair number of patients coming in the clinic who unfortunately, for way too long, have been drinking way too much. So less is more, specifically 1 or fewer drinks a day for women and 2 or fewer per day for men, no more than that. There's also some literature about sleep, and in particular, we all know the benefits of sleep, but making sure to get hopefully 7 to 8.5 hours of good rest every night. And also making sure that if you snore or you're being told that you snore, you're moving around a lot in bed. These could be signs of a sleep disorder, specifically sleep apnea or REM sleep behavior disorder. And we want to know about those conditions as soon as possible. In the case of sleep apnea, of course, there are different treatments for that to protect the brain. People who have uncontrolled sleep apnea for years and years, of course, stop breathing many times at night, every night, and that damage to the brain accumulates over months and over years and is irreversible and is associated with premature cognitive decline. So that's another issue related to brain health to focus on.
Thank you. I have a question here.
Oh, yeah. And also, I think there was some mention about genetic testing, too, that was buried in that inquiry. So here's my philosophy on genetic testing. So, you have autosomal dominant mutations that are commercially available to be tested. And that's when we say autosomal dominant, this means something that's passed throughout generations. And if Essentially the children have a 50% chance of inheriting that mutation. And this is something that leads to Alzheimer's disease in one's 30s and 40s. So these are rare conditions. They account for, I think, less than 1% of all of Alzheimer's disease. And if there is a family history of people developing Alzheimer's in an early age in the 30s and 40s, third or fourth decade of life, then I think having that testing is certainly indicated because it really helps with providing a prognosis. But again, these are really patients that are quite rare. Any clinical trial that takes place, they have to recruit patients from all over the world actually because it's so rare. Now, a lot of people come to me and say, hey, you know what, my mother developed Alzheimer's at 78. What's my risk as her child? And, there's only one kind of genetic test that you can do that may be contributing. And usually this is, a factor in someone who's developing Alzheimer's in their late 50s, early 60s. It's called ApoE4. And it's not, it's a risk factor for Alzheimer's disease. Whereas the other mutations I talked about, the autosomal dominant ones, they include presenilin 1, presenilin 2, amyloid precursor protein. These are all involved in the processing of these amyloid proteins that lead to the plaques. Well, ApoE4 is essentially a risk factor. So let's say if I were to test somebody for it who was worried about developing Alzheimer's later in life, if you're positive for it, it's not destiny. So it will increase your risk for Alzheimer's disease, but it doesn't guarantee if you're positive that you're definitely going to get Alzheimer's disease. Or let's say if I test a person and they don't have it, well, at the same point, it doesn't necessarily mean you won't get Alzheimer's disease. And so the clinical utility of this, until we have a disease-modifying drug, doesn't add much, and in fact may just lead to greater anxiety on the part of the patient. So in general, I don't recommend checking for ApoE4. The only situation where I would suggest genetic testing is if you have the autosomal dominant pattern where it's present in generations and patients who have suffered from it are quite young in their third, fourth decade of life.
Thank you. I received a question here. Will moving to an independent community hasten my spouse's Alzheimer's? He is in moderate stage now, probably.
Carrie, that's a question that we get quite often in the clinic. Those are such difficult decisions for individuals and families to make, those transitions, for many different reasons. But a lot of people do question whether such a move would be advantageous or detrimental. And I would say it depends a little bit on the individual, but in general, if someone is living, with a spouse in their home, moving to an independent living or a continuum of care community often has many advantageous consequences. For example, there are many other people around in close proximity that can help to improve socialization and casual conversation, which, as we just talked about, is really helpful for the brain. Such continuum of care communities also often have many more activities than what most of us have available to us at home, more exercise programs, and again, other socialization opportunities. And so there are a lot of advantages. And I would say, generally speaking, in my experience, once that move is made, it's generally a positive one. There is a period of maybe 1 or 2 or 3 months of stress, of course, associated with the transition, but in the long run, it's a positive thing. I would also say that if you have a spouse who has memory loss, the longer you wait to make that move, the harder it's going to be for your spouse to get oriented and adjusted to new surroundings. And so I always tell my patients that if you're considering such a move, you're better off doing it earlier rather than later, where your spouse has a little bit more memory and capability to adjust, because the transition can be much harder in later stages of the disease.
I also see a question, it's multiple paragraphs, but I think the long and short of it is about the medicines that we typically prescribe in Alzheimer's disease, drugs like Aricept and Namenda that I mentioned before, and also antidepressants, and whether or not they can contribute to hallucinations or behavioral changes. I think that's the question in a nutshell. And in general, it's a challenging situation because you have patients who come in and they have problems with their brain, and you put them on medicines that are supposed to impact neurotransmission in the brain. And it's really easy to kind of say, oh, what's causing this problem? Is it the medications that the doctor prescribed? And, I would say that in general, drugs like donepezil and memantine, they're designed to actually counteract hallucinations. Actually, this chemical that is increased by Aricept or donepezil, when it gets very, very low, it can lead to hallucinations. And drugs like that are known as anticholinergics, even like Benadryl, which we can get over the counter, will lead to hallucinations. In fact, the CIA developed some really strong anticholinergic drugs that they would use on volunteers, and through the anticholinergic action, they had horrible hallucinations. So know that the drugs that are used for Alzheimer's disease are actually doing the opposite, and we would not expect them to cause hallucinations. Memantine acts via a different mechanism, but again, I don't think it would exacerbate hallucinations. The antidepressants, drugs like Lexapro and Wellbutrin in general are well tolerated. The most common neurological side effect associated with Wellbutrin is actually lowering of the seizure threshold and breakthrough seizures, but hallucinations is not a common side effect. The drugs that I would be concerned about causing hallucinations include the drugs I already mentioned, antihistamines or anticholinergics. So antihistamines are drugs like Benadryl, a lot of these over-the-counter drugs you can get, even Zyrtec. Also, some of the medicines that you may use for bladder spasm, like oxybutynin, is an anticholinergic. And then the other category of drugs are benzodiazepines. So drugs like Valium, lorazepam, they can cause paradoxical confusion and agitation in patients with memory loss or dementia. And some of the sleep drugs like Ambien, I've seen agitation and delirium result from those. So we usually say to avoid these medicines. And then narcotics, so opioids, these also are notorious for causing hallucinations. So when we see a patient who's coming in with us to see us and they have hallucinations, we first look at the medication list, and we're trying to simplify those other drugs. We're not making changes in the donepezil or memantine or their antidepressants. And then if, let's say, we don't see any culprit drugs contributing, we may just look at their labs, make sure they don't have a urinary tract infection, which can also sometimes lead to hallucinations and delusions in these patients. Then finally, the diagnosis of exclusion is that it may just be the course of disease. So in late stage Alzheimer's disease, and also with many other dementias, one may have hallucinations. And so often one has to start a drug that will counteract those hallucinations more directly. And there are medicines such as Seroquel or risperidone. These are known as antipsychotics, and they specifically treat behaviors associated with hallucinations and delusions or false thoughts.
Thank you. We have a question here about sleep. If your loved one with Alzheimer's has ongoing uninterrupted sleep issues, sleeping through the night, I've tried using melatonin supplements, 5 milligrams. This seemed less effective than Sleep 3 made by Nature's Bounty supplements, which has 10 milligrams of melatonin, 5 of which is time released. This seems hit or miss. Are there better options or a prescription to get a spouse to sleep through the night?
So I would say that there's a strategy that we use in the clinic. So we like melatonin because it's a naturally produced hormone by the pineal gland. And so we're not introducing anything new into the body, like, let's say, Ambien. If that doesn't work, there are other medicines that can be prescribed that won't have the same severe side effects of an Ambien-like drug or a Benadryl-like drug. So one drug that I use a lot in clinic is called trazodone. Often we start at low doses, like 50 milligrams. It's a prescription drug, and it can help with sleep without causing significant cognitive impairment. There's another drug that's relatively newer, produced by Merck. It's known as Belsomra, and it acts via the orexin pathway, which is a different pathway that's involved with alertness, actually antihistamines. The reason why you get sleepy from these is because they impact this pathway. But this drug, Belsomra, is relatively proven to be tolerated well in elderly populations. And also it's helpful for what we call sleep fragmentation, where someone falls asleep and they wake up in the middle of the night. So those are two prescription options to consider that are relatively safe. The other thing I would say is that we also need to be mindful of the non-pharmacological interventions. And for instance, at Health Partners, we have what's known as an insomnia clinic, where we have a counselor who can look at various triggers for sleep or any other factors that may impact sleep negatively and help patients and families eliminate those. So I'm often prescribing a medicine and then referring these patients to insomnia clinic. The other thing to bear in mind, as Dr. Barclay alluded to earlier, is that there are certain factors that are associated with obstructive sleep apnea that can impact sleep. So someone who's snore, someone who's overweight, someone who doesn't feel well rested in the morning or has a headache in the morning, and they have unexplained hypertension. This is somebody who may benefit from a sleep study, and you may uncover an underlying diagnosis responsible for that sleep disorder, like obstructive sleep apnea, and that can be treated in a different way through a CPAP mask.
And I would just piggyback on that and add that although it's not possible, of course, for all older adults to be exercising, not uncommon to have neuropathy, foot and leg pain, hip joint issues, and so on. Trying to be thoughtful as to whether there is any opportunity to increase physical activity, even by a small degree, because of course, more movement during the day really helps to lengthen and deepen our sleep cycles at night. And also being thoughtful about making sure that the person is exposed as much as possible to bright light through the morning, afternoon, and daytime hours. And that's to make sure that the light coming into our eyes on the retinal path, optic nerve to the brain is giving the brain the right signals about when the day is day and when it's nighttime. Controlling sleep is such a hard thing for many family members. Ultimately, it is important, though, to talk to your doctor about it and manage the issue, because individuals with memory loss who have a lot of sleep difficulties, that's a risk factor for earlier transition into assisted livings or skilled nursing facilities, because it takes such a toll on family members when someone's circadian rhythms get off base and they're active at night and not so much during the day.
All right, we have a question here about testing. My wife had an MRI and EEG, which showed nothing definitive regarding her memory loss. Would you think PET scan and functional MRI would be more useful? And would neuropsychological testing provide information that these imaging procedures might not?
So I think we can both answer that. Maybe I'll have Terry talk about the neuropsychological component.
Sure, I would just say, and then I'll let Dr. Rosenblum talk more about the imaging. It's not uncommon for us to see individuals of older age who have bona fide cognitive problems, even dementia, Alzheimer's disease, with relatively normal structural imaging, like a head CT or a brain MRI. But the neuropsychological testing is, one of the most specific and detailed brain analyses that can be done. And absolutely, we see many patients with normal neurodiagnostic tests who, on neuropsychological testing, provide incredibly rich data that can really help us pinpoint exactly where in the brain there's a problem and what's going on. So in brief, the testing that we're doing over the course of 30 minutes, an hour, several hours, depending on the situation, is basically we're collecting a numeric map of all of these different brain regions along the right hemisphere, the left hemisphere, all of these different networks in the brain, so that by the time the person is done with the exam, we have this numeric mapping that we're looking at all of this rich data. And what we're looking for is unique fingerprints or signatures in the data that can tell us why a person is struggling with those cognitive skills. For example, there's a unique fingerprint for Alzheimer's disease, and there's a totally different fingerprint for vascular dementia, frontotemporal dementia, Lewy body disease. The data can also help us understand if someone's significant depression or mood problems are the primary driver, or there's a different signature for medication side effects, sleep apnea, and so on. So that's why neuropsychological testing really typically is part of a gold standard workup.
So I would just echo what Terry said. When I was in fellowship, my mentor, Bruce Miller, always said that the neuropsychological assessment is an extension of the neurological exam. And I can't do that extension. I'm dependent on people like Terry who can do this assessment. And I think it's one of the most important parts of the workup. And I would also say that the MRI, the buck really doesn't stop at the MRI. The sensitivity of this test for pathology in the brain is limited. I should also say, though, I've seen countless MRIs that have been read by the radiologist, and then I look at them and I see profound atrophy in the brain. And so as a behavioral neurologist, or as a subspecialist, we look for certain things that may be missed during the formal read. I would also say EEG probably should not be part of the standard workup for memory loss. I think that's done too often in the community. And the PET scan is something that I think is a last resort. If you do the usual assessment that includes labs, brain MRI imaging, some type of cognitive screening, the neuropsychological assessment, and you're not sure what's going on, then you can move to the FDG PET scan, which looks at brain metabolism, and as Terry alluded to, brain networks. Functional MRI is more of a research tool, has not made its way to the assessment of dementia. This may be the future, but right now that's not something that's routinely done in clinical practice.
Mike, do you want to say a few words as to whether or not these additional scans are covered by insurance or the cost involved?
Right. So, for an FDG PET scan, Medicare will cover it if you're trying to distinguish Alzheimer's disease from frontotemporal dementia. But if it doesn't get covered, it's quite expensive. And also insurance does not cover, no insurance I know covers a functional MRI. So these are not tests that are ordered quite frequently.
Okay, thank you. What are your thoughts about CBD and other non-pharmaceutical solutions for helping with sleep and anxiety in older adults?
So, I've, maybe I shouldn't admit this, but I guess, transparency is a value of mine. And so I'll just tell you, I did become one of the licensed physicians to give CBD to our patients with dementia. And maybe next week I'll see, we'll get a ton of calls from people, but I've been in this really frustrating situation where there's not a lot of evidence for medicines to be used for severe anxiety, agitation, behavioral expressions, and dementia. And, often I'm using, SSRIs, antidepressants, and antipsychotics. And, many of you in the audience realize that these antipsychotics are not benign drugs. There's a lot of side effects to them. In fact, there's a black box warning that they can increase mortality in the elderly population. So, you think about the potential of CBD, and, those side effects are relatively minimal. So my threshold for trying it has become lower over time. And so I've put about, I'd say, between 10 and 15 patients on CBD, mostly because of their requesting. And this is something that's done through the state. And so it's regulated. And honestly, I asked for a high CBD content and a low THC content, because THC can lead to paranoia and hallucinations. And at this point, I can say this is not a magic bullet. I've seen some families who say that it does nothing, and others have found that it has bought them about 6 months or so, because it was helpful for the anxiety. So there's not definitive data to guide us. We're generating that as we speak. And I think it's a go-to when there are no other solutions. There's also another question about the use of Depakote for behaviors in Lewy body dementia. And, we actually had several conversations with primary care about the use of Depakote in Alzheimer's disease. So there is actually literature that shows that patients who have chronic exposure to Depakote, they have worsened memory scores and greater brain atrophy compared to those who have not been put on Depakote. And at the same time, there's no evidence that it's beneficial in that patient population. Now, in Lewy body dementia, a lot of people are under the impression that if they're experiencing hallucinations, which are one of the core features of this type of dementia, that they should be placed on an antipsychotic or a behavioral medication, and that's not the case. Some people may be surprised to know that Lewy body responds best to drugs like Aricept, cholinesterase inhibitors, because this is a disease that results in a paucity of certain neurotransmitters, including acetylcholine. So the first line agent for behaviors in my practice is a drug like donepezil or Aricept. And then if there's still behavioral expressions or hallucinations, we may try something that has less antidopaminergic activity, like Seroquel or quetiapine. That being said, we don't have proof that Depakote hastens the decline of Lewy body dementia. And I think if you've tried the cholinesterase inhibitor, I wouldn't say it's unreasonable to use the Depakote, provided that you have good experience with it. It's an anti-seizure medication. It's not an anticholinergic. So, essentially, sometimes you get to the point where the consequences associated with the behaviors outweigh the risk, and then the risk-benefit ratio of doing the drug is favorable. So I guess my response to that question is always try a cholinesterase inhibitor first. And if that doesn't work, then, all bets are off, and you can just try and find something that works effectively in this population.
And there was a follow-up question to that. Is Lewy body dementia the same as FTD? If not, what are the differences?
Yeah, so Lewy body dementia and FTD are two different diagnoses. These are non-Alzheimer's dementia. Lewy body accounts for about 10 to 15% of dementia, and then FTD is about 2 to 5% of dementia. Alzheimer's represents 60 to 80% of dementia. Lewy body is characterized by 4 core symptoms. That includes early hallucinations, during the first year or so. Number 2 is Parkinsonism, and that involves tremor, rigidity, shuffling of the gait or walking. And then cognitive fluctuations, which kind of looks like a patient zoning out and being confused for periods of time lasting minutes or hours. And then finally, REM sleep behavioral disorder, where patients act out their dreams and thrash around in bed because their brain networks are in the brainstem are compromised. These patients have progressive decline, and they have a specific neuropsych profile that Terry may want to talk about. Now, on the other hand, frontotemporal dementia is a spectrum of disease that involves the front of the brain, the frontotemporal lobes, and there's 2 different forms of it. One where patients have what's called behavioral disinhibition, and they act inappropriately. the introvert becomes excessively extroverted. They may have what's called apathy. They lack interest in everyday things, like their job or their family. They lose empathy. So if somebody, let's say somebody in the family dies, they don't show any remorse or they don't mourn. They also may have changes in eating habits and also obsessive compulsive movements. There's another form of FTD where language is affected and patients have what's known as a primary progressive aphasia, and there is progressive loss of the ability of expressive speech. And so those are kind of two types under that continuum. Frontotemporal dementia usually affects younger individuals, younger than 60, whereas Lewy body is usually late in life in individuals older than 65. And maybe Dr. Barclay wants to say a little bit more about how the neuropsychological assessment may be helpful in those two patient populations and distinguishing them from Alzheimer's disease.
Yeah, I would say a couple of things that these are conditions that typically, from a neuropsychological point of view, can be easily distinguished from Alzheimer's disease. Most people with Alzheimer's disease, of course, have memory difficulties as a primary deficit, and maybe also some mild word finding difficulties, executive dysfunction, trouble with reasoning, insight, and judgment. In the context of Lewy body disease, we see disproportionate and really profound deficits, mainly in two cognitive functions. The first is attention and concentration, as Dr. Rosenblum alluded to earlier, this sort of waxing and waning arousal, such that sometimes people are more on and focused, and other moments, hours, days where they're profoundly confused. And then secondly, on the neuropsych testing, we see disproportionate and significant spatial deficits. So these are people who, when asked to draw simple figures intersecting pentagons or more complex designs, have a great deal of difficulty with spatial distortion and understanding the relationships in between things in space. And so that's a very typically easy profile to identify. And then with different forms of frontotemporal dementia, of course, in the behavioral variant, you have a lot of frontal lobe dysfunction, which again leads to profound deficits on testing and problem solving, reasoning, judgment, planning, organizing. And in the language variants, atypical difficulties, either understanding the meaning of words and objects or in expressing themselves. I would just also add on the care side for family members, FTD and DLB are challenging in some cases. For one, because most of the literature out there in the world or on the web pertains to Alzheimer's disease. These are conditions that are sometimes misdiagnosed more easily, particularly by non-specialists. And they involve other symptoms that can be challenging. So DLB, often frequent falls, which are really hard for family members to manage. And in the case of behavioral variant frontotemporal dementia, changes in personality that are extremely distressing for spouses and children and other people close to the individual, that can sort of mimic more of a psychiatric condition, an out of control psychiatric issue. So these are tough diagnoses and really require typically specialists to help improve quality of life.
All right, we have a few more questions here. Would Delta 8 with CBD be considered for seniors with sleep issues and anxiety also? It's hemp, it's legal and milder than marijuana-based THC, of course.
So this is a challenge with CBD products, is that it's not regulated as let's say a typical drug I would prescribe. There's no FDA approval of these, and so what I use as a physician is through the state, through the dispensaries, and there are designated dispensing pharmacies throughout the state of Minnesota. And so, my knowledge and familiarity with these other products is quite minimal. In the ideal world, I'd like to be able to say, I'm going to prescribe medical cannabis, and it should have this number of milligrams of CBD. And I can't even do that through the state pharmacies. It's a really challenging situation. So my feeling is that this situation needs to be better regulated and we need to get more data, but I unfortunately can't comment about some of these commercial products that are out there.
Okay. Do you help assisted living sites where the patient does not want to leave bed and can no longer walk? In this case, there is pain, good verbal expression, and about 30% memory loss, in my opinion.
I can take this one first. As part of our NeuroWell vision, although Mike and I don't typically go out to assisted living facilities or deal directly with care staff around these issues, we do partner with experts in the community who can get underneath this sort of thing. And so, for example, some of you may know about Jane Claremont. She's the former owner and CEO of English Rose Suites, which is an incredibly novel approach to care. She used to own a number of homes throughout the community, 6-bedroom homes that provided tailored and unique high staff to patient ratio care for individuals with dementia. And she's now retired, but she has joined forces with our center, and we now refer families to her who are dealing with this sort of thing, either behavioral expressions, as she would call behavior changes, or limitations. In this case, someone maybe being unwilling or unable to get out of bed. And how do you get underneath that? How do you identify what's really causing that, and what are the opportunities to improve their quality of life and stimulation? And so we refer individuals to her, and on a sliding fee scale basis, she doesn't turn anyone away for inability to pay. She goes in, talks to the individual, family members, the care staff, does a whole assessment, and then is able to, in many cases, get down to the bottom and change the scenario. So she's been a great resource for us.
Thank you. And I think we have time for this last question here. Are neuropsychological assessments something that are needed beyond the initial medication investigation into dementia-related illnesses? If so, at what stages or points should someone seek another neuropsych assessment?
Yeah, this is a great question. This is something that's really tailored to the individual. In some cases, people will come to us, they've never had a neuropsychological exam, and we do one for purposes of getting the specific diagnosis, initiating a treatment plan, getting them set up. And from that point on, they're managed by neurology or primary care just fine, and they may not need another assessment. Sometimes that's the case, particularly if someone is already a little bit more advanced in their disease before they come to see us. In many other cases, though, where people are coming to the clinic a little bit earlier, they're maybe at a mild cognitive impairment stage, which for many people is a precursor before onset of dementia, then we do serial testing, because it's an exquisite way, an objective way to really measure statistically what exactly is changing in the brain and how. And that serial or longitudinal testing can be really helpful to make sense of changes that are happening and update the treatment plan and really stay ahead of the curve instead of behind the 8 ball, if you will, with these conditions. So it's really tailored. Some people just get one exam, but quite a few people that we follow at the clinic are getting these maybe every 1 or 2 years, depending on the situation.
Great, and I think I'll defer in adding anything to that. And there's one more question about FTD, someone having a brother diagnosed with FTD in an older age at 76, and whether or not that diagnosis is correct. Well, FTD generally should spare memory, which it sounds like that's the case in him. But the one thing I should also say, while FTD is most commonly affecting younger folks, it's not impossible for it to affect somebody who is, in their 70s. That has been described. And now, in certain cases where that diagnosis is uncertain, and this is only in kind of really atypical presentations, there is the ability to look at the spinal fluid from patients. And we do this in our clinic when we're just uncertain, and you can actually look for the actual biomarkers for Alzheimer's disease. And that will help us say, is it Alzheimer's disease or something else? And in cases that are atypical, we will draw the spinal fluid, have it analyzed, and then look at it. And if it's consistent with Alzheimer's disease, that helps us with a very specific diagnosis. And if it's not, well, then it could be something else. In this case, maybe FTD. So I think if there are questions, that's something that can always be done.
Thank you. And we are at 12 on the dot here, at least in Central Time Zone. So thank you everyone for joining. Thank you, Dr. Rosenblum and Dr. Barclay. If you're willing to put your contact information in the chat, in case any of the attendees would like to follow up with any questions, that would be great. And a reminder to go to the conference homepage and fill out the survey evaluation. Your feedback is important to us. So make sure to do that when you can. And again, thanks for spending the hour with us. And we hope the rest of your conference is just as beneficial. Thank you.
Yeah, thanks for inviting me.